Okay, moving on, I would like to introduce our next speaker, Dr. Freya Schnabel, who is a professor in the Department of Surgery. Let's welcome Dr. Schnabel.
Okay. Thank you, Rachel. Thank you, everybody, for being here tonight. So, like my colleagues, I'm going to try to hit some of the highlights about different interesting studies that were presented at San Antonio, and I've grouped things into different large categories. So there was a great deal of discussion at San Antonio this year about expanded knowledge regarding patients who have a genetic or inherited predisposition to breast cancer. So one of the talks that was given by Dr. Fergus Catch from the Mayo Clinic, who is a very prominent researcher in the field. And he talked about studies that are being done to help us clarify what are the risks associated with some of the different predisposition genes, especially some of the ones that are newer to us than BRCA1 and 2, which are sort of like old friends and which we have a fairly clear understanding about the breast cancer risks that are associated. So for context, this was information that was published in the New England Journal of Medicine in 2015, where Doug Easton and his group attempted to give some risk estimates for patients who carry some of these less common genetic mutations that increase the risk for breast cancer. So if you look at these different risk estimates, for a lot of them, there are very large ranges, meaning we don't really precisely understand what the risks are. And several of them, even though we know that they increase the risk for breast cancer, at the time of this publication, there wasn't enough information. There weren't enough people that we knew that we could study that had these genetic mutations to help us understand exactly what the levels of risk were. So in Dr. Couch's study, they looked at data from over 121,000 individuals who had undergone genetic testing through Ambry Genetics, which is one of the big companies in the US that does genetic testing, between March 2012 and June 2016. So there were over 38,000 individuals, most of whom were female, that for whose information was available for analysis, and they were tested for 21 known and possible candidate genes that increase the risk for breast cancer. And then as a control, they compared these individuals' testing results and outcomes with a huge group of individuals whose genetic information was collected from Caucasian European populations. So this is what they found. And again, some of these are genes that we know increase the risk for breast cancer, but are much less common than BRCA1 and 2. So what they found is for these different genes that you see listed here, the odds ratio, if we compare somebody who is baseline risk, would be 1.0. The odds ratios are very, very variable. The PALB2 gene, PALB2 stands for partner and localizer of BRCA2, came out with the highest risk, even though there's a big broad range here. Some of the other genes came out with significant increase in risk, but I'll draw your attention to the idea that for a variety of these genes, the increase in risk turns into an odds ratio of around 2, which is actually a fairly modest increase in risk when we compare it to other risk factors. I'll talk about that in just a minute. Now, this large study confirmed that, again, aside from BRCA1 and 2, some of the other genes that we've become familiar with, like P53, P10, and CDH1, certainly imply an increased risk to develop breast cancer. And of course, the information about the PALB2 gene, again, confirmed a very high risk, now looking at a much larger population. So we feel that the study results are more valid. In addition, some of the really uncommon genes that we talk about, BARD1, RAD51D, MSH6, these genes increase the risk for breast cancer, but in a modest way, in a very moderate way. And it's really important for us to do these large studies because this study also clarified that a number of the genes that they were looking at did not increase the risk for breast cancer. So that nowadays when we do expanded panel genetic testing on people, we frequently don't just look at BRCA1 and 2, we do a whole panel of these genes. We need to understand in a precise way how they impact on people's risk, and it's important to know which ones increase the risk and which ones don't. And these have big implications in terms of managing our patients that undergo genetic testing and are found to have these rather unusual genetic mutations. Now, Dr. Couch showed this slide showing that the information that they were able to accumulate has changed the way we're going to look at some of these mutations and has changed the recommendations that we're going to make to people based on the genetic testing results. And I think that's great. I think it's really important to be able to not only give somebody a test result, but tell them what we're going to do about it and what's appropriate to them given their risk level. I am a little concerned about this column here, which is the column where, according to our guidelines, we can consider discussing risk-reducing mastectomy surgery. I'm sort of perturbed about seeing that column expand. I would hope that genetic testing is not something that people interpret as a means to have bilateral mastectomies, but by the same token, the more we learn about genetics, the more it requires us to be able to give people clinical guidelines and advice that's actually based on evidence and not just on our own concern. Now, remember I mentioned to you a couple of minutes ago that odds ratio or relative risk of around 2 is something that I consider relatively modest. I'm going to show you this slide just so it gives you a context. This is a paper that was published in the New England Journal of Medicine by Ellen Warner in 2011 and did a very nice job at summarizing the different risk factors that we know about for breast cancer and looking at what the relative risks look like. What's a bigger risk, what's a smaller risk, etc. And you can see from here that somebody with a 1 first-degree relative with breast cancer can have a relative risk of about 2, even if that individual was diagnosed at a later age. And sedentary lifestyle can be up to a 1.8 relative risk for breast cancer. And certainly when people have sedentary lifestyle, we like to counsel them to try to exercise more and modify their lifestyle implications, but we don't think of that as something at very high risk for breast cancer. So we need to be able to give people some context when we tell them their risk and really pick out the highest risk patients for intervention. Dr. Catch gave another talk. It was obviously his year at San Antonio. And he tried to give a talk that looked a little bit more broadly at the different predisposition genes that we know about for breast cancer. And of course, the talk began with the concept that BRCA1 and 2 are the most familiar to us. We know the most about it. There are more than 2 million patients who've been screened for BRCA1 and 2 at this point in time. And we're beginning to recognize the fact that when there's a family history of breast cancer and a BRCA mutation, that is a much higher risk to develop the disease, even than patients with a mutation without family history. We also recognize that males with BRCA2 have a 6 times increase in their risk for breast cancer. So even though the number's small, really makes them very different from their peers. But I think that what's interesting also about the knowledge as it's evolved is that not only do we know that BRCA1 carriers are at increased risk for breast cancer, but they are at increased risk for a particular type of breast cancer called triple negative breast cancer. I'm going to get back to that in a minute. And also, we are beginning to now qualify and quantify the increased risk for ovarian cancer, pancreatic cancer, and prostate cancer in males with BRCA2. So Dr. Catch feels like the more genes that we discover, the more genes that we uncover that have some role to play in increasing the risk for breast cancer, the more we will explain why breast cancer develops in patients. So I think that's true. I do think that there's a limit to what we're ever going to explain by inherited genetics, but the more genes that we identify, the bigger that slice of the pie is going to look. And what has also become clear is that it's not just the BRCA1 carriers that have a higher rate of this triple negative breast cancer, but that in some of these other less common mutations, you can also see an increased rate of the triple negative breast cancers that are not sensitive to either hormonal therapy or targeted drugs like trastuzumab. Now, I'm going to caution you about these results, and this is a caution that has to do with all of this information about these rare genetic mutations. So the caution is that if you look at that column that says cases, it will show you that in some of these categories, the number of individuals who actually had these mutations and went on to get cancer is really small. So we're going to have to test a lot more people and accumulate a lot more information before this information becomes really, really reliable. So again, this is interesting information, but need to go much further in drawing sweeping conclusions because it's based on not a lot of patients. So Dr. Couch said, we have to get together, we have to pool our information from lots of different sources so that we can understand these rare genes and what they really mean in terms of breast cancer risk. We also need to remember that some patients who get genetic testing results are told that they have variants, changes in the genetic structure that are different from the, quote, normal structure, but not clearly related to disease. We've got to go a little farther in accumulating data about that, and that we will continue to identify additional genes that may raise the rate of breast cancer in addition to other sorts of cancers. So moving on, the next study I'm going to talk to you about came from the UK. Where they did a study looking at whether or not being a BRCA carrier affected the outcome for young breast cancer patients. And this is called the Posh Study. Remember what I say every year. You can't do a big clinical trial unless you come up with a really, really cute acronym. So that's Prospective Study of Outcomes for Sporadic versus Hereditary Breast Cancer. Done in the UK, where they have great capture of clinical material. They looked at patients who were diagnosed at under 40 years of age, and anybody who had a blood sample available underwent testing for the BRCA mutations. So the analysis included almost 2,800 patients. Before breast cancer diagnosis, a few of them were already known to have genetic mutations, and then many more of them, about 300, were referred after their diagnosis for genetic testing, probably because they had a family history. And about 14% of the patients in this group, when they were tested, were found to have either a BRCA1 or BRCA2 mutation, or both, which is rare but definitely happens. Now, when they looked at the kinds of breast cancers that these individuals developed, what they found, as I mentioned a couple of minutes ago, is that people with the BRCA1 mutations had a higher rate of developing triple-negative breast cancer. So it just confirmed that fact. But interestingly enough, the BRCA2 carriers developed cancers that looked much more like the garden variety cancers seen in non-mutation carriers, looked much more like the sporadic type of cancers when you looked at their characteristics of their actual tumors. Now, here's some of the important findings. So, number one, in terms of the outcome and survival, when they compared all the patients who are BRCA carriers to those that were not, the outcome and the survivals were the same. So having a BRCA mutation doesn't make your breast cancer better or worse than anybody else's. The outcomes were the same. But if you just picked out of the group the patients with the triple-negative breast cancer, that's where there was clearly a difference in survival. So that's something we know about. When people have triple-negative breast cancer, whether they're BRCA carriers or not, it's a challenging patient population to treat. So if there's any subgroup of these genetic mutation carriers that do have an impact on survival, it is the triple negatives. Just like the sporadic patients, these patients are very challenging to treat and sometimes do not have good outcomes. Okay, so moving on to the prevention realm. I'm going to be very brief here, and I'm going to show you one slide from a talk by Dr. Powell Brown, who is, again, a internationally known expert in breast cancer prevention, who was part of a bunch of the early prevention trials and is now working at the MD Anderson Cancer Center in Houston. So I think it's kind of clear to those of us who work in the field, and probably clear to a lot of the survivors and knowledgeable individuals in the audience, that when we talk about preventing breast cancer in high-risk women, all of the prevention efforts to date have focused on hormonal therapy. Tamoxifen, aromatase inhibitors, and so on. And that's kind of where we've been stalled, for lack of a better term, for quite a while. There's been nothing really new to come out in years. Now, so I said the one slide I'm going to show you about this talk is that, we understand that hormonal therapy is good. We understand that it can be effective, but we also understand that it's not appealing to a lot of patients and that there can be really significant side effects. Today, looking out of the box, there's interest in a variety of new areas for prevention, including some of the anti-HER2 drugs like trastuzumab, lapatinib, vaccines, etc., and then a bunch of other categories of drugs, some of which I don't know what they are, or I didn't know until I looked at this slide, like rexinoids, everolimus, which is an mTOR inhibitor used in treatment of certain breast cancers, like PARP inhibitors. Again, lapatinib, which is a drug that's like trastuzumab, an anti-HER2 drug, and then a variety of other different medications that are under consideration to begin clinical trials for breast cancer prevention. So the good news here is that people are looking outside the box and trying to expand breast cancer prevention beyond just hormonal manipulation, and I hope that this is going to come up with a strategy that's effective and has less side effects. Speaking of hormonal therapy, there's a lot of concern among patients who are treated for their breast cancers with hormonal therapy and patients who are recommended hormonal therapy for prevention. There's a lot of concern about side effects. And we know that even in women who take hormonal therapies, whether it's tamoxifen or aromatase inhibitors, that it's very difficult for some patients to remain on these drugs for the prescribed period of time because of side effects. So this was a study that came from the UK where they looked at compliance and adherence with hormonal therapy in patients who participated in the IBIS-1 trial, which was a prevention trial. So their goal was to look at the role of menopausal symptoms on long-term compliance and adherence in patients in this prevention trial, which included high-risk women aged 35 to 70. When they looked at the results, they defined adherence to treatment as women who remained on the drug for at least 4.5 years, understanding that 5 years was supposed to be the time frame. Now, they compared women who were on the placebo arm of the trial and women who were on the tamoxifen arm of the trial. So in neither group did 100% of patients remain on the drug. In the tamoxifen arm, the adherence was about 62%, which really aligns with what you see in most of the large clinical trials. About 60% of patients stay on the drug long term. But what was also interesting is that only 71% of the patients in the placebo arm stayed on the placebo during the treatment. So what does that mean, right? That's an interesting observation. And if you look at the adherence in a graphical form, you see that there's a big drop-off in both groups kind of at the beginning, and there certainly is a differential in terms of the placebo patients were able to stay on trial longer than the tamoxifen patients, but that really by the end of that 4.5 years, you're looking at less than 3/4 of patients remaining on the drug, both groups having a significant fall off. So what's that all about? They asked people about the side effects that they were experiencing related to the drugs. The placebo patients are in blue. And again, if you look at the comparison between the blue and the red, you can see that in most situations they're kind of close to each other. Patients on placebo reported, in many cases, similar symptoms to patients who were taking tamoxifen. There was, however, a difference in gynecological symptomatology and a small difference in hot flashes. So what did we conclude from this trial? The investigators said, well, they were kind of happy that 2/3 of patients on the trial adhered to the study or placebo drug. I kind of think that's sort of a meh result. I don't think that's anything to really kick up your heels about. They found that the dropout rate was the fastest in the first 12 months of therapy, and they felt that there was some association between menopausal symptoms and adherence to the trial, but what they also saw, as we just noticed, that placebo arm patients dropped out too, and they're calling that the nocebo effect, which I think is kind of cute. Now, why is this interesting? Why was this worthy of a presentation at San Antonio? I think it reminds us that it's hard for people to stay on hormonal therapy. I think it reminded us that when patients are taking a drug for prevention of a disease that they don't have, their incentive, their impetus, their engagement with the trial is probably less than when people are taking a drug to treat a disease that may be life-threatening for them. So I think that's a big difference. But it also tells us that some of the symptomatology that people describe may not really be related to the drug that they're taking. So I think that there was a lot of interest in that. I found this very interesting. It also makes me concerned about some of the trials that are being conducted now looking at patients with DCIS and trying to treat those patients with very early breast cancer with hormonal therapy for 5 years. I think those trials are going to be very handicapped by the fact that we're likely to see only this level of adherence. So that's what I took away from this. Very interesting. Switching to surgery, I'm going to talk about a couple of things with you. So one study that I want to present to you, partly because we participated here at NYU and it's so interesting, is a new method of localizing non-palpable breast lesions for surgery called the SCOUT guidance system. So as a lot of people in the room are probably aware, when people come to surgery because they have an abnormal mammogram or a breast imaging test, they have a non-palpable breast abnormality, the way that the radiologists help us surgeons to find that abnormality in a focused way used to be for many years put a wire in the breast, right, with some local anesthesia to say, okay, that's where the problem is, that's the roadmap. So that was very effective and worked really well, but it was very hard on the patients. So the question was, can we find something better? Can we find something easier? So this SCOUT guidance system is something really new to use a different way to localize these abnormalities with no wires, with nothing radioactive, and allowing the patients to do the localization not on the actual day of their surgery, so they don't have to march around in different places in the medical center when they're not eating and drinking and they're fasting and so on. So it utilizes, oh, this isn't working, right? So the SCOUT system utilizes this little chip. It looks like a lightning bolt that you can see in the middle of the breast here. Somehow I'm not getting to the right side. Can you see it? So that little lightning bolt is like a GPS or a radar. It's actually an infrared reflector. It's not radioactive. And the radiologists put it into the breast with local anesthesia at some point during the week before surgery. We actually have FDA approval for this up to a month before surgery. And they give you some local and they put it in just like the clips that go in when people have biopsies. And then we have a little probe that we put on the skin, and it's an infrared, and when it goes right over the chip, it goes beep, 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 and then we know, okay, that's where it is. Here's the incision. And it's really fabulous for the patient because it decouples the surgery from the localization. They can come for their surgery, go directly to the OR. They don't have to wander around the medical center. It's done with local anesthesia, no wires sticking out of the breast. Absolutely terrific. So we participated in this multi-institutional trial looking at this new technique. A lot of success with the trial. There were 153 patients and 152, I would say. The reflectors all worked well. One of them at another site had migration of the reflectors. And in terms of margins, we sort of found the same rate of positive margins that you see in breast surgery overall. So it wasn't better than the other procedures, the wire localization procedures in terms of achieving good margins. But certainly I think from the patient experience perspective, this is a home run. And we've now integrated that into our work here at NYU, and we have found great physician and patient satisfaction with this. So lastly, I want to talk to you about one last trial that deals with an interesting aspect of surgery that's rapidly evolving, which is what do we do about looking at lymph nodes in patients who undergo chemotherapy prior to surgery? As Dr. Perez introduced, this is called neoadjuvant chemotherapy. It's used for patients with more extensive or serious breast cancers prior to surgery in order to make sure that we're prioritizing their systemic treatment and also to allow us to watch how their disease responds. So again, very frequently used in patients with locally advanced or high-risk disease. Now, we know that when patients have early stage breast cancer, the way that we do the surgery involving the lymph nodes has become much more refined over time. We don't remove all the lymph nodes under the arm. We try to focus on the ones that are most connected to the cancer, called the Sentinel nodes, right? We map out which lymph nodes are the most connected to the cancer, and therefore many patients are able to have fewer lymph nodes removed, but still give us good information about what's going on under the arm. But the question is, are those techniques reliable in patients who have undergone preoperative chemotherapy? So the investigators in this trial started out by reminding us that people have done it. They've mapped out the sentinel nodes in patients with more advanced disease, And most of the time you can find the sentinel nodes, which is cool. However, the false negative rate, very disappointing, in almost 11% of patients in this prior trial, taking out those lymph nodes didn't really give you a clear understanding of what was going on in the axilla. In other words, sometimes surgeons just took out those first few lymph nodes and they had no cancer in them, but there was cancer left behind. So that 10.7% was considered not acceptable. Just showing you another study that was published 10 years ago in Cancer, again, it showed that when patients had before surgery, had chemotherapy before surgery because they had extensive disease with positive nodes, known disease pre-treatment in the axilla, you could identify sentinel nodes, but the accuracy was not good. 25% of patients in this trial, the sentinel nodes had no cancer in them, but the rest of the lymph nodes had some cancer in them. So again, very, very skeptical about using this technique. And this is just 2 other trials that showed similar results in terms of real lack of reliability of the sentinel node procedures in patients with more extensive disease. So this trial that was presented at San Antonio tried to refine this a little bit more by looking at patients who were having chemotherapy before surgery, but splitting them up into patients where we knew there was disease in the lymph nodes, we knew that they had had biopsies, that there was cancer in the lymph nodes, and comparing them to patients who might have had more extensive or high-risk disease, but that there was no disease in the axillary nodes before they began treatment, and split them up into 2 groups and then said, okay, now let's take a look at the sentinel nodes and let's see if that process works. So in the first group of patients where we knew it was known before their chemo that they had cancer in the lymph nodes, once again, you can map out which are the sentinel nodes. That was something that was feasible in about 80% of patients, not terrific, but reasonable. And in 103 of the 244 patients who had sentinel nodes identified, the sentinel nodes showed no cancer. But out of those 103, in 19 of them, when the remainder of the lymph nodes were looked at as part of the trial, they had at least one positive node or more. So that the false negative rate was about 12%. That's what they reported, but I did the math. By me, it's 18%. So I don't know what kind of numbers they were using. What calculator was on the fritz, I can't really say. Either way, not a great number. Not a great number. When we do sentinel node procedures in patients who don't have neoadjuvant chemotherapy, you know what the false negative rate is? 4% or less. This is not so good. Now, interestingly enough, though, when they split out the patients who had chemotherapy but did not have disease in the lymph nodes to begin with, right? They looked at that segment of the population separately. And they did sentinel nodes. 139 of those patients had positive sentinel nodes, and most of those patients went on to have the rest of the lymph nodes removed, okay? But in 432 patients where the sentinel nodes showed no cancer, 14 of them went on to have the rest of the lymph nodes removed, and only 3 of those 14 had any positive nodes. So again, if you look at the 432 patients, only 3 of them were documented to have positive nodes after negative sentinel nodes. Now, they said, okay, so that's how it went surgically, but what happened to the patients? So clearly, in this second group that we just talked about, where there was no disease in the lymph nodes before treatment, the patients all did really well. Only 1 patient had any disease that recurred in the axillary area within 3 years of the treatment. Other patients had other events, including metastasis and so on. But in that particular group, the majority of whom only had sentinel nodes done, it looks like in the long run didn't make any difference in terms of their outcomes. So what are the take-home messages from this study? The author said that for patients who had neoadjuvant chemotherapy before surgery and were known to have disease in the axillary lymph nodes before treatment was begun, the sentinel node procedure is probably not the right thing to do. The false negative rate is significant. We don't really know how the patient's outcome is impacted, but when we compare it to the standard use of this technique, it doesn't really seem to match up to the statistics that we expect. However, in patients who, before they started their treatment, had no evidence of disease in the axillary lymph nodes, it seems like doing a more limited removal of lymph nodes is reasonable and safe and did not have a negative impact on anyone's outcome. So the take-home message to me is that it's really important when people come to the breast cancer diagnosis to be very, very clear, to work them up carefully and investigate carefully and really understand what is the extent of disease before any treatment is done, because that is going to direct us in terms of the safety and efficacy of their surgery. So in summary, we're learning more and more about genetic predisposition to breast cancer far away and beyond BRCA1 and 2, but we do need to learn more before we can advise patients with the rarer genetic mutations about what they ought to do. It's encouraging that we're looking at breast cancer prevention outside the box of hormonal treatments. I didn't mention anything about DCIS today, but we're still looking at stratifying the risk for patients with DCIS to figure out who needs radiation and who doesn't. We're doing better using new technology for preoperative localization of non-palpable breast abnormalities. The management of the axillary lymph nodes after neoadjuvant chemotherapy should be very much directed by the pre-treatment status of those lymph nodes, and this underscores the need for complete imaging and even possible biopsy of axillary lymph nodes before starting upfront chemotherapy in those patients. So thank you very much for your attention, and we'll answer questions at the end.